What if I told you that some of the most important signs that a patient is about to crash is not found on the monitors usually?
They are found in day-to-day conversation, breathing pattern, facial expression that experienced nurses often picked up every time they work a shift.
Yes, so today we are taking you behind the scenes of what nurses notice before a patient crashes. So we'll share what the gut feelings that nurses get, and we'll also share some stories, some real life stories to help you gain more insights into what nurses actually are paying attention to.
Welcome to Married2Nursing,
the podcast where we pull back the curtain on healthcare.
Hello everyone, thank you for joining us in another episode of Married2Nursing. I'm Anna. I am a nurse who has now transitioned into entrepreneurship, and my husband, Armand, is still a nurse, still working actively as a nurse. But before we get started, here's a little disclaimer. Everything that we share on here is based on our general experiences as nurses in the different departments or in the different hospital healthcare settings that we have worked at. So there are no patient identifying informations that are going to be shared on here. So anything that you hear that may sound like someone that you know is just coincidental. It is not specific to any single patient. Okay. So I'm going to be asking him the questions because he has worked in the IMU, which is a step down unit from the ICU. So he has taken care of a lot of patients who are very sick, who are critically sick, maybe not ICU sick, but my experiences are more in the general medical unit. Mm-hmm. So today I'm going to be asking him all the questions about what they usually in that setting pay attention to when a patient is about to crash. So they can catch it before that actually happens. All right? You ready?
Let's go.
Are you sure? You ready for this?
I need to go back to my memory bank.
Yes, because I have some good questions. For anyone who is just watching this podcast for the first time, he's currently working in the operating room. So it's been a couple of years now since he left the bedside, working in the IMU, the intermediate unit, which is a step down from the IMU.
Exactly.
ICU, sorry. Okay, so question number one. So we're just going to jump right into it. Are you ready?
I'm ready. Let's do this.
So let's start off with, what are some of the subtle signs or warning signs that nurses notice hours before a patient actually crashes?
Okay, so besides looking at the monitor, the monitor gives us a lot of information. Vital signs, which are blood pressure, respiration. Respiration we count, or heart rate. But the most important thing is, is to look at the patient's behavior. Mm-hmm. We often say, don't treat the machine, don't treat the monitor, treat the patient.
Right.
So the patients will tell you more than what the machine can actually tell you. So subtle signs is usually, I would like to go back to breathing, because breathing is always changes fast.
Number one. Mm-hmm.
Number one. Because blood pressure, you check it. When you check it, that's when you see, okay, it's too high or it's too low. Heart rate, the machine will show you, okay, is this person's heart beating too fast, or why is it beating too fast? Mm-hmm. Those are like, data. Those are information you can gather from a machine. But as far as the patient is conversation, patient telling you, I feel funny. What is going on? When a patient says you feel funny, you're like, okay, you need to start digging.
Right.
What do you mean by funny? Or the poor appetite. They say your patient is eating fine, and then all of a sudden it's like, okay, I can't eat no more. Or like my stomach hurt. I feel like I'm extremely full. Why is that? Or I feel like my heart is jumping out of my chest. Especially when the patient say, I feel like my heart is jumping out of my chest.
It's like your antennas just go up.
Exactly. Okay, because your heart should not be jumping out of your chest.
Right.
So those are some basic things that we can look at. Like I say, I feel funny, or you walk into a patient room and you see the patient like breathing fast, or just throwing things left and
sweating.
Right. I almost forgot about that. Sweating, hyperventilating. Sweating is usually because the patient is putting up too much effort
to breathe,
and they're using a lot of muscles that they don't normally use, so they start sweating. Oh yeah. What's up?
What about confusion?
Confusion, that's a nice one, especially with the elderly.
Right.
I would say that it took me a while to grasp that one, because with the elderly, confusion happened with infection.
Okay.
Infection, especially in the urinary tract, in the bladder.
Mm-hmm.
So you will see your patient just doing fine, and all of a sudden experiencing confusion. They will start talking about things that are not there. And you need to pick that up right away. Say, okay, this could be an infection, and start doing what is necessary.
Right. So not to deviate, because I have a follow-up question from what you just said, but not to deviate too far. How do you differentiate between a what they call a sundowning in the elderly, where when it gets to a sunset, the elderly tend to become confused? How do you differentiate between that and, okay, this is confusion based on UTI, based on infection? How is there a way that a nurse is able to pick up on that, or is it just through medical history?
So number one, through history. Okay. If the patient has a history of sound downing, then and sound downing is often because the patient has an underlying condition like Parkinson's disease or Alzheimer's disease that alter the patient's way of the patient's brain, mental function. So as far as confusion that is not related to sound downing is a patient who, number one, has never exhibited sound downing, and number two is the confusion happened during the day. Okay. The sun is not setting.
It's not setting yet.
And the patient is showing you signs of confusion. So you're like, okay, well, my patient has never had sound downing, and we are bright at noon or 10 a.m. and my patient is telling me that they are seeing things or talking about things that are not there.
Right.
So with experience, you gain those little subtle clues. I was like, okay, I need to look into this a little bit more. Why is this happening?
Okay.
And who do I need? Do I need to inform the doctor? And so we can, move on from there.
So have you ever had or walked into a patient's room and immediately felt like something wasn't right, even before you looked up at the monitor?
Oh, yeah.
Because I know in the IMU unit, the step down unit, patients are usually hooked up to the monitor, unlike the medical unit where they're not.
Yes, exactly. So the monitor is very helpful, but your observation is number one. We often talk about subjective data, right? Subjective information. Those are things that you cannot put number onto. So yes, you walk into a room and if the patient is purple or blue when it's supposed to be not that color.
Right. But have you had an experience of it, like a personal, maybe one of your patient, you walked in and just immediately looking at the patient, you knew something is not right before you even glanced at the monitor?
Oh yeah, I think in one recent episode we talked about that. I went to go pick up a patient. I walked into a room and I looked at this patient and he had all the signs. I didn't even look at the monitor. Heavy breathing, sweating, and being uncomfortable, where it's like the patient was acting like I should take off my clothes, like I need to breathe. I'm sweating. I can't catch my breath. Before I didn't even look at the monitor. I just immediately screamed for help.
Oh, wow.
Somebody, hey, something is going on here. Because that was not my patient specifically.
Okay.
So I just, call that nurse, because this is not, the patient should not be like this. And before the nurse can even come back to the room, I was already calling
emergency,
pulling the code blue light.
Okay.
So, and multiple times I've been in patient room, the color change is very obvious. Unfortunately for people of color, you have to look at the lips, or the nail bed. So you can.
So that means you have to be really paying attention to the patient. Like you have to be observing the patient to notice, for people of color, to notice the lips, or because what if the person has dark lips?
Yes.
Or nail beds?
So what if the patient has dark lips, the tongue?
Oh wow.
You see, so when you are talking to the patient as they are opening their mouth to talk, it's not you are not just looking at the lips or the mouth or the sake of looking at it is you are saying, okay, is the color of the tongue okay? People who smoke, for example, often the nail bed doesn't have the pinkish color that a nail bed should have. It will be darker. So that's why you have to pay attention to different things. Like, okay, what else on the body can I look at to pick up that color?
Wow. Yeah. So as a nurse, you have to be very vigilant and pay attention. So what happens when a nurse does not pick that up?
Well, you are heading for a disaster.
I guess that's self-explanatory.
It's self-explanatory. but I mean, the grace that I can give is that some of those things you learn to pick it up. Okay. You know, it's through experience. You're not gonna be a nurse on day one and pick it up. Yeah, so you pick it up through experience, and you pick it up through whomever is teaching you or who taught you how to be a nurse on the floor in those departments where patient can go from zero to bad in a split second.
I guess that's why it's also important when you are training a new nurse or a brand new nurse to pour into them that it's okay, it takes experience. Because I know there are some new nurses who are like, oh my gosh, I'm not cut out to be a nurse because how did you know to pick that up? And I didn't even see it, or, things like that. So it's like, it's important that as experienced nurses that we pour into those new nurses and let them know that it takes experience and just give themselves grace. Yeah. And also to trust their gut feeling.
Exactly.
Right? So the nurses, go ahead.
Oh yeah, trust their gut feeling, because I had an oriental like that one time. We were working side by side, and she just came to me. She's like, "Hey, Armand, something is off." She trusted her gut feeling, and I remember, like, for me, when my colleague come and tell me, "Hey, something is off," I'm running, like, okay, because I want to make sure. Let's be preventive. Even if everything is fine, then make sure that, okay, nothing is off. So she's like, hey, I feel like something is wrong. I'm like, what patient? We ran into the room. The patient was just slumped down.
Oh wow.
Patient wasn't retaining that posture where you feel like, okay. And immediately, okay, we flattened the bed and called the cold brew and started compression. And this patient, lips were blue.
Oh wow.
Eyes were rolling back. All those things that shows that the patient is crashing. Yeah.
So can a patient look completely stable and still be on the verge of crashing?
Yes, definitely. Those time is when a patient tells you, like, I feel like something is off. Okay. A patient is completely stable, talking, moving. And when a patient tells you, I feel like something is off, you, depending on the critical nation of the patient, when they come to the hospital, the critical, you stabilize them. Okay. And then, let's say it was hard to stabilize them, and then all of a sudden they're telling you they are fine. Most of the time, where in some instances when the patient say I'm fine, it's a precursor of something happening, something about to happen.
The calm before the storm.
Exactly. So when patients say, "Oh, I'm fine now," I guess it's the now that just give it like a little twist. Like, okay, no, okay, you have to have you have to start observing that patient even closer to make sure that, okay, I'm fine, that they are saying is truly I'm fine, not a precursor to something else happening. Going to happen.
Okay. So what would you say is the difference between a patient who is simply having a bad day and one who is beginning to deteriorate? What's the difference between a patient okay, this patient is fine, but they're just having a terrible day, versus one that's, it looks like they're going down?
So yeah, that one also comes down to a combination of looking at the patient's behavior and also looking at the data that you are getting from
the monitors, vital signs,
the labs. A patient can be having a bad day simply because they're in a hospital, away from the family, away from regular day-to-day activities and, having a little bit of depressive state. So when you combine, and also the history, like the conversation that you have had with the patient, is he somebody that has signs of deterioration that can deteriorate, right? So if they are not that person, then you can, make the judgment that, okay, they are just depressed or not
just having a rough
having a moment.
And also the report that you get from the previous nurse.
Exactly.
Because the nurse will let you know what the trend has been for this patient. Is this patient usually like this, or what kind of day or morning or night this patient had? Maybe they didn't sleep good through the night, because you nurses come in the night.
We don't let you sleep. Oh, that's a story for another day. We don't let you sleep. We come in that room and check on you like, no man's business.
So as a IMU nurse, a step down unit nurse, when do you decide it's time to call the rapid response team, the emergency unit? When do you decide it's time to push that code button or to escalate? Let me not say the code, maybe that's going too far, but when do you, because rapid response can be called before a patient actually codes.
True.
So rapid response is almost like a bridge between, okay, before this patient completely crashes, let's fix it. So when do you decide to call them or escalate with the physician?
Yeah. So your gut, trust your gut. When you put together all the information that we just talked about, what the monitor is telling you, what the labs are telling you, what the results of whatever test they are performing is telling you, plus the patient's behavior or the way the patient is talking. So at that moment, you need to trust your gut and be like, okay, this patient is going downward, or something is not quite right. I can tell, especially, how it's at the beginning of the shift or at the end of the shift that things like this happen.
During report. Because there's no one really monitoring the patient. But that's why most institutions have put in place a bedside nursing shift report. So as both nurses are exchanging or giving report and the other person receiving, it's happening with the patient, right in front of the patient. So there's an eye on the patient to prevent those moments. But yes, it's usually during those times that the patient decides to crash.
Exactly, because I have so many examples.
Sure, we want to hear them.
Bedside nursing. We walk into the room doing a report, and we're talking about the patient, the nurse that is leaving, giving me all the information, and then we notice that an access, which is a catheter to give medication that was close to the neck, was laying on the patient's chest.
Oh wow!
Like, okay, and we got closer, and there was blood pooling in the back.
Oh wow!
So she pulled the catheter.
Was the patient confused?
Yes.
Okay.
This patient was an elderly person, and the patient was bleeding out. Oh wow, that morning was hectic.
Right. I can imagine.
From 7, I remember clearly, from 7 to like 11, we're constantly working on that patient.
So you were the oncoming nurse, you were the day shift nurse, okay?
My ongoing nurse didn't leave because she got stuck there too, because she had most information about the patient at that time. And we call rapid immediately. So when we roll the patient, it was a lot of blood. So we have to get lab to make sure, if we need to start transfusing right away. And this was a lot of unit was spent, a lot of blood unit was spent that day.
Wow. And the patient was okay?
The patient was okay. Okay.
Were they transferred to ICU at that point?
Yes. Or? The reason why that, at that time, the reason why it took so, like I say, from 7 to 11 is because there was no ICU bed.
like we spoke about on previous episode.
So, the rapid response never end up staying in the room with the patient until the bed became available.
Wow. Okay. Now let's talk about the vital signs, the monitors. I know we've talked about beyond the monitors, what the nurse picks up, like the facial expressions, the cues that they pick up. Now, what about the vital signs, the monitors, do the nurses pay attention to, or what signals something is about to happen?
Okay. So with the vital signs, the monitor, blood pressure is super important in a sense that the force that your heart is pumping the blood is what's sending blood to your brain, to all your vital organs.
Right.
So as a blood pressure drops, it's the amount of blood going to those vital organs decreases. So when that happens, those organs can start to deteriorate. All right. And there is a number we look at, you know, the patient has a blood pressure of 80 over whatever number, and it keep going down 70, 60s. It means that the vital organs are not getting enough blood. So we pay, I don't want to use a technical term here. We pay close attention.
No, let's keep it simple that everyone can understand.
We pay close attention to that blood pressure. And as the blood pressure drops, guess what goes up? The heart rate. Because the heart is pumping faster to try to get that blood to where it needs to go.
Right.
So when you see those trends, you know, you're like, okay, those trends, when you see those trend of blood pressure dropping and heart rate going up, you're like, okay, something is up here. Right. And then the reverse is also true. Okay. Blood pressure is going high, which is, you know, now you are looking at like, you know, 150s, 170s, or all the way to like 200. That's too high. When a blood pressure goes that high, it can lead to stroke. You know, too much pressure it's like too much pressure on the pipe.
Right.
So, and blood pressure is going up, and all of a sudden heart rate drop.
Everybody's running.
Everybody's running, you know, because when the heart rate drops, that means there's a bleed somewhere. You know, the pressure burst, the pipe had burst somewhere.
I like your analogy. Okay.
So the pressure had burst somewhere, and the patient is starting to bleed out somewhere. So you have to figure out what is going on. So that's why the monitor is very critical as well for patients that we have in those type of department, IMU, ICU, because in those departments, we take vital signs like almost every 2 hours, every 4 hours.
Okay.
On the med-surg unit is usually 3 times a day. When a patient is becoming critical, where you have to increase the rate of taking those vital signs, that's when they move them to.
I know some nurses in the medical unit get frustrated when you have to take frequent vital signs. Like, can we just move this patient to IMU so they can be hooked up to the monitor that automatically does that monitoring for the vitals? What about temperature?
Okay, so change in temperature is often linked to infection. Okay. Right. So
because we hear so much about sepsis, and I know one of the things is the temperature change that cannot be controlled no matter what.
So true. So temperature, we use different monitors for that, right? In most department, in most hospital. So when you start noticing a trend, in increased trend in temperature, you also have to go back and check it more often.
Okay.
Let's say the patient say, I feel hot, whatever. You change the temperature, and it's above what the threshold should be, and you give medication to bring the temperature down. It comes down while the medication is working fine, and then a few hours later it goes back up. Okay, so what is causing that?
Yeah.
And it can go the other way too. The temperature can, sometimes it's not always about temperature going up. Temperature can also go down. So when those things are happening, then the next step is to do, to check certain labs. Okay, why is this happening? And there is a specific lab we check for that. And if we check that lab and then is out of ordinary, then you start doing blood work.
So what lab is that?
You check for lactic acid concentration.
At what point do you do a blood culture?
So if the lactic acid is high or too low, then you do a blood culture. And blood culture is very specific. Also, you have to do a certain way and to try to find out what is causing this elevation in temperature. And besides that, let's give the example of a patient who cannot pee, and we have to put a catheter, So those can harbor infection. So the first thing, if you start seeing the lactic acid going up, and if the patient has a catheter, the first thing you see the doctor say, take that out.
Yeah, because those urinary catheters, it's a huge source of infection.
It's a huge source of infection. The Medicaid doesn't like those things.
they won't pay for hospital-acquired infections.
Yeah.
So you mentioned something about the trend in the temperature going either way, and it reminded me of a question that I wanted to ask, because I know most patients and family members think, and we've talked about earlier in this episode about the blood pressure trending upwards, but what about downwards?
Oh yeah, the blood pressure trending downwards.
Like a low blood pressure.
A low blood pressure. Yeah, I mentioned that too, where it's like when the blood pressure is going down, that means there is not enough blood going to vital organs, right? And we look at specific number to tell us, okay, hey, why is this going so? And we have intervention that we can do to bring the blood pressure up.
Okay. So taking care of a patient, it's a whole community approach, or should be a community approach. I know the nurses, the physicians, the whole hospital system tries to get the family involved in the patient care, so that it can be an optimum outcome for this patient when everyone is involved. So how can communication between the nurses and family help identify a patient that's deteriorating sooner than later?
Okay. Like you say, it's an interdisciplinary work.
Right.
Everybody is involved, doctor, nurse. So how can communication, as a family member of a patient, you probably most likely know that patient more than anybody else, right? Because you've probably been taking care of that person your whole life, or
you've been around the person.
You've been around. So if you see something that is off, talk to the nurse. And also be an advocate. Don't be scared that, I don't want to say this, I don't want to say that, right? Don't be scared of, I don't want to say the other. Just say it. Better to say it than not to say anything and something else end up happening.
Right.
So you need to be able to communicate with your nurse, of course, in a respectful way.
But I feel like theoretically, in a perfect world, that's good, that's fine, that should happen. But I know I've seen, and I'm probably guilty of it as well, where we tend to just focus on the patient and forget about the family member in the room. In fact, it gets to the point sometimes where, because a nurse is already so tasked with so many patients that they have to take care of, they just want to do what they have to do so they can move on to the next patient. So the family members are often neglected or not brought into the care, because in doing so, it would require more time from the nurse and all of that. So how do you, now I want you to speak to the nurse to almost like encourage the nurse that, speak to the nurse. I don't want to put the words in your mouth, but.
No, of course. Which is true, because there's a lot of things to accomplish on a day-to-day basis, during a shift.
Right.
There's a lot of things to accomplish. But it goes back to you as a nurse slowing down in the midst of the fastness of everything.
Right.
Be self-conscious and include that family member in the conversation. For example, in the OR, when we are about to take a patient back to the operating room, most people will have a patient there. When we come to talk to the patient, ask those questions, we don't address the family member. We say hi to everybody, but we start addressing the patient first. The patient first, as long as the patient is mentally intact to respond to those questions. And after the patient answers all those questions, then we turn to the family member. Do you have any question? But you introduce yourself first, because in those in that environment, you want the patient to know what's going on, blah blah blah, and you address to the family member, hey, what is going on? On the floor, you do the same thing. You introduce yourself. You're gonna be the nurse, and when the patient is giving you information that you feel like those information are not correct, then you refer back to the family member. Okay, hey, is this what is right?
Okay, so 2 more questions. First one, what role does experience play in, and I believe you've touched on this a little throughout this conversation, what role, if any, does experience play in nurses recognizing when a patient is heading towards a crisis?
Experience plays a huge role. I don't think I'm not going to dismiss that. Experience plays a huge role, because people come to the hospital with different diseases or different things going on, right? If you are only exposed to one thing and never encounter anything else before, then you will not know how to treat it. You will just treat everybody as you will treat everybody as a cookie cutter.
Okay.
But everybody is not.
It's not the same.
It's not the same. So experience is very important. The more exposed you are to different things, the better nurse you become. Right. That's why, for personally, I've never liked to just settle in one department. I jumped around. I mean, now I'm okay where I am because I think I've been exposed to enough stuff. But I think all those departments that I've got a chance to work at gave me kind of like a book of things I can, you can
pull towards.
Yeah, a pocket full of different things that I can.
And made you more discerning or more alert to pick up these warning signs.
Exactly.
So does that mean that as a patient, if I was a patient, I should be a little skeptical about having a new nurse take care of me?
Not at all. Not at all. Not at all. And it's because a new nurse will have resources. A new nurse is going to have resources around to help her do her job. If a nurse doesn't know what is happening, there are people in the department that have been there for years that can, the nurse can go back to and say, okay, this is what I'm seeing. This is what I'm seeing. I don't know what to make out of it. Even doctors do that. I don't know if I should, maybe we can cut it off later, but during surgery, doctor will call other doctor and say, this is what I'm seeing. What do you think about it?
Right. It's like consultation.
Consulting exactly.
Other physicians. So you can consult your fellow nurses.
Exactly.
To say, come look at this. What do you think about this?
Oh, and I did that. That's why we have charge nurses in unit, because charge nurses have more experience.
Right.
And if you don't feel comfortable with what you're seeing, or your gut is telling you, hey, something is not right, get your charge nurse.
Right.
That's what they are there for.
Right. So I want you to look at the camera before I ask my last question. I want you to look at the camera and speak to that new nurse that's probably having a hard time in his or her nursing career right now.
Okay. I want you to know that as a new nurse, whatever you are going through, everybody had been through it. Don't feel shy. Don't feel scared that you need help. Best to have the help and avoid any issue than not reach out and then things go south. So as a new nurse, stick in there, keep pushing. It's hard. You're dealing with people with different background, different expectation, but the longer you push, the better you're gonna become. So don't feel discouraged. Just keep on pushing. Yes. That's all you have to keep doing.
Yes, and utilize the resources.
So when you get home, talk to your loved one that can help you overcome, or friends that can help you overcome all those feelings that you have about whatever is going on. But the most important thing is just don't give up, keep pushing, and you will get better at it.
Yes, you heard him. It's doable,
Mm-hmm.
and you have resources, you have help. Just use them, okay?
Yeah.
All right, so last question. If you could teach every patient and caregiver one warning sign to never ignore, what would it be?
One warning sign to not ignore. When a patient or your loved one is saying, I don't feel okay. They're already in the hospital and say, I don't feel okay. It's broad, but call the nurse.
Mm-hmm.
The loved one is saying, I don't feel okay. We are not asking you to read the monitor.
Right.
It's all about what the conversation you are having. Your loved one is breathing funny, or saying I feel dizzy. They're trying to sit up and they're like, I'm feeling dizzy.
Like
don't let them get up.
Right.
Because you don't want them to fall. We hate falls. We hate falls. All right.
So is there anything else that you want to share regarding this topic before we end for today?
So nurses are there to take care of you, the patient, the family member, and everything. We do everything toward that goal. We may come in and act like, not act like, but we come in and there is nothing to do, which is a good thing because there's nothing really critical happening. And sometimes we can come in and things go like fast, which is also a good thing because we catch things on time. So ultimately, our job is to take care of you, the patient, to make sure the patient is fine, and to make sure that the family member is also comforted.
All right. Well, that is it for this episode, everyone. We hope that you enjoyed today's episode, but we do have one question for you, and you can leave that in the comment section. And that is, have you ever had a moment when you knew something was wrong before anyone else did? Share your experience with us in the comment section. Let me read that one more time. Have you ever had a moment where you knew something was wrong before anyone else did? And that could be you as a patient, family member, caregiver, or even as the nurse. We would love to hear your experience. Please leave that in the comment section. If you're watching this episode on YouTube, please hit the subscribe button so you can join this growing family, this growing community, and also give a thumbs up for this episode. And if you're listening in on Spotify or Apple Podcasts or wherever else you get your podcast, be sure to follow and like and leave a review as well. We greatly appreciate it so we can continue to make videos like this for you all to keep you informed and empowered the next time that you are a patient or you have a loved one going into the hospital. All right. Well, thank you so much once again for joining us on this episode.
Thank you.
We'll see you next time on the next one. Until then,
next time.
Take care.
Bye.